realization that in fact, I personally grew up being a translational researcher to begin with, doing studies of neurobiology, neuroimaging in psychosis going back about 30 plus years. And I began to realize that a lot of what I did and papers that I wrote didn't have much of a relevance for immediate patient care. So there is a big evidence practice gap in healthcare. And practice has lagged behind knowledge by several years. And so on that note, it's important to also realize that state of US healthcare is in a serious fragmentation, high prevalence of chronic conditions, but high level of fragmentation across mental health, primary care, substance use, social services, criminal justice, education, etc. About half of US residents or less receive effective care for chronic conditions. For mental health, it may be even less. Just a third or less receive even minimally adequate treatment. So, if I were to ask you, how long does it take for a research finding to be translated into clinical practice, and what proportion of all research is applied to clinical service settings in the community? The answer is quite sobering. And there is what is called a 17-year gap from a research idea in a lab to its being translated to clinical practice. At least 17 years. It may be more. In many cases, there are many papers that just sit in their filing drawers and never reaching the clinical practice level. And studies suggest that probably around 1/6 to 1/7 of all research is applied to clinical service settings in the community. I told you about how my own research began. I was very interested in how the synapses work and how there might be too much synapse pruning and how that might lead to brain atrophy and cognitive impairment. I did that for a number of years, and I was also running a clinic at that time. But my realization led me to focus on shifting my research into more clinical trials, what is called T1 and T2 kinds of studies. That is, T1 is studying a clinical intervention to see if it is even applicable to humans. T2 is to see whether it actually works, the intervention works in a patient population, in a research setting. Doing your standard, clinical trial, whether it is supported by industry or by an NIH or O1 grant. So you really take a very pure approach to finding the right kind of patients, exclude a lot of people, and see whether a particular intervention works. I did that for a number of years. We developed an approach to cognitive remediation and tested that in a number of randomized controlled trials and so on. But still, we were unsatisfied. So from the time I was studying the brains to the time we were getting results from clinical trials was probably about 17 years. You saw that 17-year gap. But we still were not able to apply that in practice because, I would get questions from all over the country. Can you give us CET? Can you tell us how we can apply it in our frontline clinic? I was helpless and I had no idea that how that would work. So we developed a multi-site implementation-oriented trial, which is still going on with Dr. Russell Shute as my co-principal investigator. He's in the audience here. our question was, do these real world, do these treatments that are developed in a ivory tower clinic actually apply to the real world in the community? So that's a question which is called T3. So in my case, this transition from T1 to T3 has taken almost 25 years. But the studies suggest that it's at least 17 years. So this is what, is kind of the backdrop for understanding implementation science. So the pipeline concept of disseminating research to get evidence-based practice. People like us, we grew up in the, in the culture of writing grants, writing papers, and, competing for grants, getting grants peer-reviewed, and then publishing papers and so on. It takes a long, long time. And really, you feel that it's not making its impact into the community. And that is where this funnel really is an important concept. After decades, probably about, as I said, 14% of all research gets implemented in the community. So this is an important concept to keep in mind. And how does one address, and what are the roadblocks to reduce that research to practice gap? First of all, one needs to know how to implement any evidence-based treatment from an academic clinic to a lower resourced setting. Secondly, one needs to understand what are the strategies to improve provider uptake of the interventions, and how treatments can be generalized to the community. How can the data from the academic centers be used to improve and scale up and spread? And so this is a big bucket, and there's a very leaky bucket. So you lose a lot of potential benefits by not addressing these kinds of questions. So that is where implementation science comes in. Implementation science is the study of methods to promote systematic uptake of research findings in clinical practice, in routine practice, and hence to improve the quality and effectiveness of health service and care. And there is what is called a PDCA cycle. That is a fundamental running principle for these kinds of implementation strategies. It's called the plan, do, check, and act cycle. Develop a strategy, execute the strategy, analyze outcomes and determine success, and implement any improvements and iterate this process. This is a moving cycle. So that is what implementation science is all about. And there are two types of implementation studies. One is simply observe. These are observational studies of how changes happen from efficacy studies to effectiveness studies, and then implementation studies. An important concept here is to distinguish between efficacy studies and effectiveness studies. Efficacy is whether a treatment works in a very controlled setting, in a typically an academic setting. Effectiveness is how does this treatment work in the real world? And thirdly, implementation research, and that is it really accepted by the provider community? Is it implemented in the community? So those are the implementation trials. And an important principle in implementation science is to identify barriers for implementation and facilitators of implementation. We'll come to that a little bit again more. And there is a framework called the EPIS framework, and that is explore the need for change in a system, prepare to integrate any intervention, get external support, internal support, then actually implement, put the program into place, and then, of course, sustain it, embed the program in a given institution, and find strategies for sustaining it in the longer run. And there is another framework called the Re-aim framework in implementation science, which is about how do I reach the targeted population? How do I know my intervention is effective? How do I develop organizational support to deliver my intervention? And how do I ensure the intervention is delivered properly? So this is called the Re-aim framework. And another important concept in implementation science is involving stakeholders. And stakeholders would include not only patients and families, typically having a consumer advisory board like we have, and I'll tell you a little bit more about that, would be of great value. And researchers, clinicians, payers, and also regulators. Those are all the people that would ideally need to be involved in developing any kind of an implementation for healthcare service, improving outcomes. So that's where the second important principle comes in, which is called learning healthcare system. What is a learning healthcare system? So the Institute of Medicine, about 20 years ago, came together to take stock of medical research, and realizing that this big research to practice gap. And so they developed this framework called learning healthcare system, which is basically a continuous quality improvement system that improves its own quality and efficiency by integrating data. As we take care of patients, collect data in a systematic way, and then feed that back into improving the care. So unlike this traditional research to practice, where the research is done in academic settings and then the 17-year gap, and then try to apply it into practice, here it is reversed. Take care of the patients, do the practice, but do that in such a way that you're collecting systematic data, and then you have a system whereby that data is used to improve individual patients' care as well as the system's effectiveness. So I'll give you some examples. We are part of what's called MapNet, which is the Massachusetts Psychosis Network, which is one of those learning health systems. So here, if you look at the knowledge practice data cycle, what the kind of things that we do is we train individuals, clinicians across multiple clinics in the state of Massachusetts in evidence-based practice, various aspects like psychopharmacology, resilience training, supported and employment, and so on. We do monthly webinars on each of these for clinicians. I can say more about that if people are interested. And Kelsey Johnson, who is our coordinator, should be in the audience here as well. And so that then is combined with a uniform assessment of outcomes using a battery that I'll show you in a moment, and assess fidelity of the different clinics to best practice care, and then monitor fidelity over the course of time, so that then we also collect basic real world data, and that data tells us in an ongoing way as to how patients are doing. And having a data dashboard gives us an ability to provide a clinic level feedback. So that is the learning health system as an example from MapNet. And this is our MapNet battery, which is a real world kind of assessment. We train the clinicians around the state on administering this kind of a battery. A lot of these are patient self-reports of psychosis, life events, medication side effects, adherence, treatment adherence, quality of life, and client satisfaction, and so on, and some clinician ratings, including functioning, symptom severity, substance abuse, family involvement, and so on. So we published a paper last year based on these principles in schizophrenia research, which kind of summarizes a lot of what we do. We have every year a strategic planning meeting supported by the DMH. And then, we support development of new clinics, supervise evidence-based practices for new and existing coordinated specialty care teams, and we help implement a standardized assessment battery. We do monthly webinars, and you all at Mass Mental would have access to participate in all of these. And I think you should be getting those links every now and then. We evaluate fidelity of the different clinics. We are developing ways to collect, organize, and analyze assessment data and provide a visualized report back to the clinics. So this is kind of a measurement-based care at a clinic level, which I'll mention again in a moment. Another example that I would like to state is an NIH study that we participated in with Vinod Srihari as the leader in Connecticut. What we found was that if you identify a risk factor for negative outcomes and intervene at a population level, you can actually see results at a population level. So this is another example of a learning health system. For example, we identified that treatment delay or duration of untreated psychosis was a factor in poor outcomes. And then in the experimental site in Connecticut, we know Srihari's clinic, it's called the STEP clinic. They intervened across the state of Connecticut by public mental health campaigns to reduce this treatment delay so that people came for intervention much earlier. And then we showed that led to an actual reduction in the reduction in the treatment delay. That I don't have this slide here. So we actually published that treatment delay, duration of untreated psychosis, was reduced in the state of Connecticut by this kind of a public mental health campaign. Another example of a population level intervention. So there are other examples. Low fidelity to coordinated specialty care is what we have been monitoring. So our interventions involve evidence-based practice training, capacity building across the clinics. And we recently looked at the data as to whether there is a relationship between improved fidelity and better outcomes. So we indeed found, Nicole DeTore has a paper in submission at this time. We're really excited about this finding that if clinics are more adherent to best practice care, their outcomes actually get better. So this is a population level intervention. This is just another example of implementation. So let's go to the last part of what I'm going to speak on, which is how can we as clinic leaders improve the system to improve outcomes in individuals like Keith. So the lessons that Keith's case teaches us are, number one, we need to look at institutional level relapse rates, for example, institutional levels of recurrence of substance abuse and functional impairments and outcomes, and also treatment adherence and so on. So those are the kinds of parameters that we need to be monitoring, and they are all addressable and amenable to intervention. To give you an example, um, over the last several years, John Torres in our group has been pioneering this concept of digital phenotypic monitoring, where using a combination of patient reported self reports of their symptoms, their behaviors, monitored by smartphones, both passive monitoring in terms of their activity levels, sleep patterns, and so on, and also their um, engagement in clinical services and treatment adherence and so on. One can combine such data on a um, database dashboard on a smartphone and use machine learning to identify who might be the people at the highest risk for relapse. So, using a machine learning model called anomaly detection, he was able to show that you can predict relapses about 1 to 2 weeks before they actually get hospitalized. So, this may give us an ability to intervene by perhaps escalating their level of care, individualized medication management, escalating psychotherapeutic services and crisis intervention, and so on. So active data, passive data, symptom self-report, GPS, accelerometers, they're all valuable in this regard. The smartphone approaches can also give us an ability to intervene in terms of, uh, you know, smartphone-based psychotherapeutic approaches, CBT, emotion regulation, and also a crisis hotline that families can access before relapse, and so on. Similar approaches could be developed for substance abuse reduction as well. Integrated dual diagnosis treatment, contingency management programs, peer led support groups, harm reduction. And one could consider implementing such monitoring and interventions for physical health itself as well, by combining lifestyle interventions, digital coaching, integrating smoking cessation, wellness groups, and so on, and have the data inform us as to who might need these interventions and appropriately referring them. So, what is critically needed is ongoing data collection, ongoing monitoring, and a back end machine learning assistance like an AI supported analysis, and then using such data to predict relapse patterns and real time personalized treatment plans, monitoring effectiveness, and also embedding these learning mechanisms into routine practice. So, in summary, the approaches into how learning health systems work would be you collect data uniformly and then analyze these data and use those data for decision making in clinical practice. So basically, from practice to data flow, from data flow to knowledge flow, and from knowledge flow to practice. This is the learning health system cycle. So data-driven feedback loops need to be set up, and an important concept here is what is called measurement-based care. If there is a way in which one could track the different symptoms over the course of time, the clinician is able to act in a timely manner. For example, patient fills out rating scales on a smartphone daily, and the ratings suggest worsening psychosis and treatment non-adherence. So, which might indicate to the clinician to increase level of care and more frequent visits. Patient gets better and the hospitalization is avoided. This is the ideal desirable outcome of measurement-based feedback. And it could be worked at a group at a clinic level as well. And so this is a study that was published a couple of years ago by a Montreal group. They developed a measurement-based care in a first episode psychosis program, and they developed an algorithm where, based on ongoing data collection at periodic intervals, the system in a de-identified way might be able to identify which are the individuals that need clinical attention. Are they the ones that are psychosis getting worse, but adherence is poor? And so they flag them for clinical attention and give de-identified feedback to the clinicians, and the clinicians can then take it up and intervene appropriately, whether the dosage adjustments, considering clozapine, referrals to substance abuse counseling, and so forth. So any such system needs to be sustained. So making it an institutionalized approach of data-driven decision-making, engaging family and caregivers in treatment planning, leveraging any grants, public or private funding, and ensuring continuous adaptation to emerging insights. So this can be a transformative model from crisis management to proactive data-driven psychiatric care. And integrating AI, predictive analytics, and patient engagement can have a lot of dividends. And this can lead to real-time interventions to improve clinic-level outcomes, and not only and across diverse psychiatric conditions. So I'll stop there to see if there are questions. We have about 10 minutes. So this is an important model that is emerging in the field. All models could be wrong, but some models are useful, and implementation science could be a good, useful model. And a number of people I have to thank here, including DMH, Margaret Geyer, Ikra, Kelsey. Kelsey is our master coordinator. Oshin, who helped with the data. Raquel, who's a co-investigator on our MapNet project. Dr. Dostonger, who runs the LEAP site, which is closely affiliated with what we do at MapNet. Ananya and Pega, who are research coordinators. So thank you all very much, and I will stop my slides here so that we can see each other. Thanks.
Great. Thank you so much, Kesh. I'm also going to stop the recordings so that people can more freely and comfortably ask any questions. And I know that this is a client that is known to our services, so we'd be interested in hearing from those who work with this client. But Rajiv, let me, a second.